Welcome back to the Deep Dive. Today we are undertaking a really deep, specialized mission. We're going into a highly focused area of pharmacology. We're talking about the drugs that control, well, the most powerful and certainly the most physiologically vital involuntary muscle contractions in the entire human body. I mean, the uterus.
Yeah, absolutely.
This is a space where, the margin for error is just razor thin because we're talking about either starting these powerful contractions or stopping them completely.
Leaving them cold.
Right. And all while balancing the critical needs of two patients. Yeah. The mother and the fetus.
Then that razor-thin margin, that's really our guiding principle today. Our mission, as you said, is to master this information, like the elite professionals who navigate this clinical space every day.
Ah.
We need to focus intensely on the precise molecular mechanisms, the non-negotiable protocols, and importantly, the severe risks involved. The goal is, well, complete intellectual mastery of uterine stimulants, the oxytocics and uterine relaxants, the tocolytics, drawing every critical piece of information from the source material provided.
Absolutely. So to frame this, before we jump into those specific drugs themselves, we really need to understand the tissue they're targeting. We know the uterus has those two primary layers. Right?
Exactly. You've got the inner lining, the endometrium. That's mostly where things like estrogens, progestins, and their antagonists act.
Okay.
But for today's topic, for motility, for the contractions themselves, we are laser focused on that thick, muscular middle layer, the myometrium.
Right, the muscle.
Now, while the myometrium does get nerve input, both sympathetic and parasympathetic, the drugs that really matter here, the ones we're digging into, are those that act directly on the muscle fibers themselves.
And what seems to define this whole field, reading the sources, it's all about context, isn't it?
Yes, that's the fundamental principle. It overrides everything else. The responsiveness of the myometrium to any drug is profoundly altered by the hormonal state and the stage of gestation.
So a drug might work completely differently depending on when it's given.
Massively differently. A uterus in early pregnancy, highly resistant to stimulants. But a uterus at term, it's exquisitely sensitive. You simply cannot separate the drug's effect from the hormonal environment it's operating in.
Okay, let's unpack this then. Starting with the drugs designed to ramp up motility, the uterine stimulants. And the absolute foundation here, the historical anchor, it has to be oxytocin. The history here is actually kind of shocking, isn't it? Considering how precise this all is now. The sources mention crude pituitary extract being used way back in 1909 for labor.
Yeah, 1909. Imagine. But for decades after that, there was this huge confusion.
What was the issue?
Well, it was a massive pharmacological puzzle. Practitioners knew this pituitary extract did two things. It caused uterine contractions, and it had an antidiuretic effect, meaning it reduced urine output. The controversy was whether these two very different actions came from one single compound or two separate ones.
And figuring that out was key.
Pivotal. It wasn't until 1953, quite a bit later, that the mystery was definitively solved by Duvigneau. He identified, figured out the structure of, and then actually synthesized oxytocin, clearly separating it from vasopressin, which we also know as ADH, antidiuretic hormone.
So these two incredibly vital hormones, one basically controlling blood pressure and water balance, the other controlling these powerful muscle contractions and things like bonding, they're structurally almost identical.
Essentially, yes. Kissing cousins, as you put it. They're both classified as nonapeptides.
9 amino acids.
Exactly, sequences of 9 amino acids. And the really staggering thing is they only differ at 2 spots in that sequence, positions 3 and 8.
Wow.
That tiny, tiny change gives rise to 2 dramatically different primary physiological functions. It's just a remarkable example of nature's precision engineering.
And the way they're made adds another layer. They're not actually produced in the pituitary gland itself where they end up being stored.
Correct. The synthesis happens upstream, you could say. In the nerve cell bodies, located way up in the hypothalamic nuclei, specifically the supraoptic and paraventricular nuclei in the brain.
Yeah.
From there, they travel down the nerve axons and are stored in the nerve endings within the posterior pituitary, the neurohypophysis.
And our sources highlight they're stored in a particular way, not just floating around loose.
No, definitely not. They're packaged neatly within granules, and they're complexed or bound to specific binding proteins called neurophysins.
Neurophysins, got it.
These proteins basically manage their transport down the axon and keep them safely stored until the signal for release comes.
And the signals for release are usually quite specific.
Generally, yes. For oxytocin, the classic reflex triggers are things like coitus, the process of birth itself, parturition, or suckling. For ADH, it's more about osmotic changes, like if you infuse hyperconic saline, or if someone's severely dehydrated, or during a major hemorrhage.
But the sources also remind us that, well, life isn't always that neat. Things like pain or stress can trigger both.
Yes, exactly. Non-specific stimuli like pain, significant stress, even just apprehension can cause both hormones to be released simultaneously.
So you might get a mix.
You might, but the ratio, the relative proportion of oxytocin versus ADH that actually gets into the circulation that varies widely depending on what the primary trigger was. The body kind of fine-tunes the release based on the immediate need.
Okay. Now let's get to that aha moment, the mechanism of action on the uterus itself. For me, the most fascinating detail was that oxytocin works completely independently of the nervous system. The uterus doesn't need a nerve signal to contract from oxytocin.
That is the defining feature of its action on the myometrium. It bypasses the nerves. The action is mediated entirely by these highly specific receptors on the muscle cells themselves, G-protein-coupled receptors, or GPCRs.
GPCRs.
When oxytocin locks onto these receptors, the main thing that happens, the primary signal pathway, leads to depolarization of the muscle fibers.
And depolarization, that's all about calcium ions moving, right?
Precisely. That depolarization triggers a crucial influx of calcium ions, CK2+, flooding into the muscle cell from the outside, from the extracellular space.
Okay, calcium comes in.
But wait, there's more. That's only half the story for generating such a powerful contraction. It's really a two-pronged attack. The same GPCR activation also stimulates something called phosphonocetide hydrolysis. This generates another molecule, IP3 inositol triphosphate, inside the cell.
IP3.
And IP3's job is to trigger a massive release of stored calcium from intracellular compartments like the sarcoplasmic reticulum.
So you get calcium rushing in from outside and calcium being dumped out from internal stores all at the same time.
Exactly. That coordinated massive increase in intracellular calcium is what generates that tremendously powerful coordinated contraction. It's quite elegant, really.
It really is.
Yeah.
But as we said earlier, the drug's useless if the muscle isn't listening. Which brings us back to that profound hormonal control over sensitivity. The uterus is like the ultimate biological sensor in this context.
It truly is. It's constantly gauging the hormonal environment.
So how does the body prime this sensor, get it ready for labor?
Estrogens. Estrogens are the key sensitizers here. As pregnancy progresses, rising estrogen levels dramatically increase the number of oxytocin receptors expressed on the surface of those myometrial cells.
So more targets for the oxytocin to hit.
Precisely. That's why non-pregnant uteri, or those in early pregnancy, are pretty resistant. The sensitivity starts low, then it increases progressively throughout the third trimester. And then right near term, just before labor starts, there's this sharp, almost exponential spike in sensitivity.
A huge jump.
A huge jump. Then after delivery, during what's called the puerperium, that receptor density, and therefore the sensitivity, drops back down quite rapidly.
What about progesterone? Does that play a role?
It does. Progestins generally tend to decrease sensitivity, sort of counteracting the estrogen effect, but the sources note that in vivo, in the actual body, this dampening effect seems less marked than the really powerful sensitization driven by estrogen. Estrogen seems to win out near term.
It's like this incredibly fine-tuned system designed for peak efficiency at that one critical moment of labor. Okay, let's look at the 4 key actions of oxytocin, starting with the obvious one. Its specific action on the uterus.
Right. At low doses, and these are the doses we use carefully for induction or augmenting labor, oxytocin produces what we call phasic contractions.
Phasic, meaning they come and go.
Exactly. This is absolutely essential. It means there's full, crucial relaxation in between the contractions. This allows blood flow to return to the uterus and placenta, preventing fetal hypoxia, lack of oxygen.
Okay, that's critical. What about high doses?
High doses are dangerous. They cause the uterus to become tonic, meaning it clamps down and stays contracted. The resting basal tone increases. It doesn't relax properly between pushes. That's bad news for the beta.
And there's another crucial distinction, isn't there, compared to the next stimulant we'll talk about. The contraction pattern is regionally specific with oxytocin.
Yes, and this is a lifesaver, quite literally. At term, the enhanced contractility is restricted mainly to the strong upper part of the uterus, the fundus and the body.
Okay.
The lower segment, the part near the cervix, is not strongly contracted. In fact, it might even be relaxed by oxytocin.
Why is that so important?
Because it means the baby's descent through the birth canal isn't mechanically blocked by a tight ring of muscle at the bottom. This is a key difference from other stimulants like ergometrine.
Got it. Okay, action number 2 is the famous milk ejection reflex, the letdown reflex.
This is the second classic function, yes. Oxytocin targets specialized, smooth muscle cells that surround the milk-producing alveoli in the breast. These are called myoepithelial cells.
Oh, myoepithelium.
It causes them to contract, squeezing the milk out of the alveoli and into the wider milk ducts or sinusoids, where the infant can then suckle it out.
So clinically, this means oxytocin can help if someone has breast engorgement because the milk isn't getting out properly.
Exactly. If the problem is inefficient ejection, oxytocin can help. But it's important to note, it will not increase overall milk production. That's governed by a different hormone, prolactin.
Okay, good distinction. Action number 3, the cardiovascular system, CVS. We need to be clear on the blood pressure effects here.
Right. So conventional doses, the low, slow infusions used in labor, they're generally neutral on systemic blood pressure. No major change.
But higher doses.
Ah, that's different. If the dose gets high, or if it's given as a rapid bolus, which shouldn't happen, you see transient but significant vasodilation, blood vessels relaxing.
Which would cause?
A brief, sharp fall in systemic blood pressure. And the body reacts to that. You get a reflex tachycardia, the heart beats faster to compensate, and often flushing of the skin.
Interesting.
And it's a key observation, kind of a historical footnote now, that this vasodilation effect is most pronounced in chickens, which is actually why chickens were used for the bioassay, the biological testing of oxytocin activity back in the day.
Huh, chickens. Any other CVS effects?
Yes, one more important one. It causes marked constriction of the umbilical vessels after delivery. This helps them clamp down naturally and stop bleeding from the cord stump.
Right. And finally, that structural link to vasopressin to ADH comes back to bite in action number 4, the effect on the kidney.
This is probably the most dangerous pharmacological overlap, clinically speaking.
Mm-hmm.
While those conventional low doses are generally ineffective on the kidney, high doses of oxytocin exert a potent ADH-like action. Remember, ADH's job is water retention.
So high-dose oxytocin makes the body hold on to water.
Exactly. It reduces the excretion of free water by the kidneys, leading to decreased urine output.
And this is where that potential disaster scenario, water intoxication, comes from. Can you walk us through how that happens? It sounds really serious.
It is potentially lethal. It's often described as a perfect storm of factors converging.
Okay.
First, you have the ADH-like action from high-dose oxytocin, making the kidneys retain free water. Second, patients undergoing long inductions or augmentations are often receiving large volumes of intravenous fluids, IV fluids, to stay hydrated.
Right, makes sense.
Third, and critically, if the patient has any pre-existing compromise, maybe she has toxemia of pregnancy, like preeclampsia, or underlying renal insufficiency, her body simply cannot handle that extra fluid load or effectively excrete the retained water.
So it all builds up.
It builds up rapidly. The combination leads to hyponatremia, low sodium levels in the blood, which causes cerebral edema, brain swelling, pulmonary edema, fluid in the lungs, seizures, coma, and potentially death. This is exactly why oxytocin infusion is not something to be taken lightly. It requires precision and constant monitoring.
Wow. That sounds like a recipe for catastrophe if not managed meticulously. Okay, let's talk kinetics, how the body handles it. Being a peptide, it makes sense. It's inactive if you swallow it, right?
Yep.
Needs injection.
Correct. Oral administration won't work. The routes are typically intramuscular, IM, intravenous, IV, or rarely as an intranasal spray for milk ejection issues.
But the most important pharmacokinetic fact, the one that really defines its clinical use, is that incredibly short half-life.
It is extremely short. The plasma half-life is only about 6 to 12 minutes.
That's fast.
Very fast. This is partly due to rapid breakdown, metabolism in the liver and kidneys. But here's the genuine pharmacological marvel, something quite unique.
Let's say.
The pregnant uterus itself and the placenta, elaborate meaning they produce a specific enzyme whose job is to break down oxytocin. It's called oxytocinase.
Wait, the body makes a specific pregnancy enzyme just to destroy oxytocin. That sounds like evolution building in a safety switch.
It is absolutely a critical control switch. Oxytocinase is an aminopeptidase, and it's detectable in the mother's plasma during pregnancy. It ensures that once the placenta is delivered or the need for high oxytocin levels passes, the body can clear the hormone extremely quickly. And it's the short half-life that makes oxytocin the preferred drug, the drug of choice, for that delicate clinical situation of induction of labor or treating uterine inertia, those weak contractions we talked about.
The protocol sounds very careful, slow, measured infusion.
It has to be. Typically, something like 5 international units, IU, of oxytocin are diluted in 500 milliliters of a compatible solution, like saline or glucose solution. That gives a concentration of 10 milli-IU per milliliter.
Okay.
The infusion must start very low, maybe zero point 0.5 to 1 milli-IU per minute, which is like 0.05 to zero point 0.1 milli-IU per minute from that dilution. And the rate is then very carefully, progressively increased, maybe doubling every 15-30 minutes, but it's strictly titrated against the uterine response. You watch the contractions.
What's the goal?
The goal is to achieve contractions that mimic natural labor strong enough, frequent enough, maybe 3 contractions in 10 minutes, but critically with that full relaxation in between. You're aiming for effective labor, not inducing a dangerous, continuous uterine spasm.
But the real clinical mastery of oxytocin, reading the source, seems to hinge less on how to mix the drip and more on knowing when not to use it. That checklist. Those 6 essential conditions that must be met before you even think about starting the pump. This feels like where the real professional knowledge is tested.
This checklist is absolutely non-negotiable. Failure to adhere to it leads directly to those severe adverse effects we just discussed, uterine rupture, fetal distress.
Right.
So before starting, the clinician must confirm, 1, the presentation is correct. The baby needs to be positioned properly, usually head down.
Okay.
2, the fetal lungs are mature, usually confirmed by dates or specific tests if preterm. 3, there's no cephalopelvic disproportion, CPD. This means the baby's head isn't too large to fit through the mother's pelvis.
Makes sense.
4, no placenta previa where the placenta is blocking the cervix. 5, critically, NO signs of fetal distress already present. The baby must be doing well before you stress it further.
And number 6.
Number 6, no significant uterine scar, usually from a previous C-section or other uterine surgery, as this increases the risk of rupture under strong contractions.
If any of those are compromised, you risk disaster. Which brings us back to why oxytocin is the preferred method for augmentation, despite the risks, but only when all those checks are clear. Why choose it then?
There are 3 main advantages directly linked to its pharmacokinetics and specific action profile we discussed.
Okay.
First, that short half-life allows for quick control. If the contractions become too strong or too frequent, hyperstimulation, or if the baby shows distress, you stop the infusion and the effect wears off rapidly within minutes.
Right, the safety switch.
Exactly. Second, the low concentration achieved via that slow titrated infusion allows for normal, full relaxation between contractions. This is vital for maintaining adequate blood flow to the placenta and protecting fetal oxygenation. And third, critically, because oxytocin doesn't strongly contract that lower uterine segment, the baby's descent isn't mechanically hindered by a tight band of muscle. It helps the top push effectively while the bottom accommodates.
Okay, let's just underline those adverse effects one last time, because they really underscore the danger of using it incorrectly, or injudiciously, as the source puts it. We're talking potentially lethal outcomes.
We absolutely are. The mechanical injury risk is paramount. You can get rupture of the uterus, especially if there's a scar or CPD. You can force the baby's presenting part through an incompletely dilated cervix, causing severe maternal or fetal soft tissue injury.
Oh.
And critically, acute fetal asphyxia oxygen deprivation if the contractions are too strong, too long, or too frequent, cutting off that vital placental blood flow.
And the other major risk.
And of course, the water intoxication risk we detailed earlier, due to that ADH-like effect at higher doses combined with IV fluids, especially dangerous in patients with toxemia or kidney problems. It needs vigilant fluid balance monitoring.
Okay. Before we move off oxytocin entirely, let's briefly touch on the analogs drugs designed to tweak its properties slightly.
Right. There are a couple mentioned. First is desamino-oxytocin. This is formulated to be absorbed through the lining of the mouth as a buccal tablet.
So no injection needed.
Correct. It's used sometimes for induction, or to help the uterus contract down after delivery, promoting involution, or managing breast engorgement. The source notes it's convenient, but the absorption and effect can be less consistent than the standard injected form.
Okay. And the other one?
The other one is carbetocin. This is a newer, long-acting analog. Its key feature is its prolonged duration of action compared to regular oxytocin.
So why would you want long-acting?
It's specifically developed and used for the prevention of uterine atony, where the uterus fails to contract properly after delivery and the resulting postpartum hemorrhage, PPH. Especially useful after a cesarean section where you want sustained contraction without needing a continuous IV drip running for hours. Ah, okay. Targeted use for PPH prevention. All right. So we've mastered the precise, short-acting scalpel that is oxytocin. Now let's look at what sounds like more of a systemic sledgehammer used for stopping massive bleeding, the ergot alkaloids, specifically ergometrine, also called ergonovine, and its derivative methylergometrine. Here's where it gets really interesting, because the contrast with oxytocin couldn't be starker, could it?
No, the contrast is night and day, and it absolutely dictates how they are used clinically. You cannot substitute one for the other.
How so? What's the main difference in action?
Well, remember, oxytocin at proper doses gave us those phasic contractions with full relaxation in between.
Yeah.
Ergometrine and methylergometrine do the opposite. They dramatically increase the force, the frequency, and the duration of uterine contractions. They produce a sustained, powerful, almost clamp-like tonic contraction of the entire uterus.
Tonic, meaning no relaxation. Very little relaxation. It squeezes the uterus down hard and keeps it squeezed. And most importantly, unlike oxytocin, their stimulant action involves the lower segment of the uterus as well. The whole thing clamps down.
And that difference in lower segment contraction, that fundamentally explains why you absolutely cannot use ergometrine during labor itself, right?
Exactly. Contracting the lower segment tightly while the fetus is trying to pass through is incredibly dangerous. It can lead to entrapment of the baby, prevent descent, and cause severe maternal trauma, even uterine rupture. It's completely contraindicated before the baby is out.
Okay. And the mechanism is different too, not peptide receptors like oxytocin.
Totally different. Ergometrine isn't a peptide. It acts as a partial agonist, meaning it stimulates, but maybe not maximally, on two completely different receptor types: the 5-HT2 serotonergic receptors and alpha-adrenergic receptors.
Okay, serotonin and adrenaline pathways. What about sensitivity? Does the uterus get more sensitive at term like with oxytocin?
Yes, similar pattern there. The pregnant uterus shows a marked increase in sensitivity to ergots as term approaches. And critically, that sensitivity peaks at term and remains very high in the early puerperium, the period immediately after delivery.
Which is exactly when you might need it most.
Precisely.
Pharmacokinetics, again, seem to really distinguish these drugs. Oxytocin had that super short half-life, 6 to 12 minutes. What about ergometrine?
Again, a massive difference. The sources confirm ergometrine is rapidly and almost completely absorbed when given orally. That's a big convenience factor compared to needing an injection or infusion like oxytocin.
Right.
Its onset of action is fast, about 15 minutes if taken orally, around 5 minutes if given intramuscularly, and almost immediate if given intravenously in an emergency.
And the duration?
Significantly longer than oxytocin. Its plasma half-life is around 1 to 2 hours, but the clinical effect, that strong uterine contraction from a single dose, can persist for 3 to 4 hours.
Right. So that powerful, sustained, long-duration contraction squeezing the whole uterus, including the lower part, it must be reserved for one very specific, critical clinical scenario.
Its clinical use is almost exclusively focused on the control and prevention of postpartum hemorrhage, PPH. That's bleeding after delivery.
How does it work for PPH?
That sustained tonic contraction it produces literally squeezes the entire uterus into a hard, contracted ball. This powerful mechanical compression clamps down on the large spiraling arteries that run through the myometrial muscle meshwork. These are the vessels that bleed profusely from the placental site once the placenta separates. Ergometrine basically acts like a physiological tourniquet from the inside.
Wow. Okay, so it clamps down the bleeding vessels. Is it used alone?
Often given intramuscularly right after the baby's shoulder is delivered or immediately after the placenta comes out as prevention. In cases of severe active bleeding, sometimes a combined injection is used, like ergometrine 0.5 milligram plus oxytocin 5 IU, to get both an immediate effect from the oxytocin and that sustained grip from the ergometrine. Symptomotrine is the common name for that combo.
Given its powerful systemic action, clamping down blood vessels potentially elsewhere too, the contraindications must be pretty extensive.
They are absolute, and many relate directly to its effects on the vascular system. Ergometrine must be avoided in any patient with pre-existing vascular disease like Raynaud's phenomenon or peripheral vascular disease.
Okay.
Also contraindicated if the patient has existing hypertension or toxemia of pregnancy, preeclampsia, because the potent vasoconstriction can trigger a hypertensive crisis or even stroke.
A serious risk.
Very serious. Furthermore, if there's any suspicion of sepsis, infection, the vasoconstriction can dangerously reduce blood flow to the extremities, potentially leading to the horrific complication of digital or even limb gangrene. And of course, as we stressed, it is strictly contraindicated during pregnancy, before delivery, and before the delivery of the placenta, which marks the end of the third stage of labor. Using it too early can trap the placenta inside, also avoid in liver or kidney disease.
And there was that sort of neuron side effect related to milk production, a neurotransmitter thing.
Yes, an interesting point. If high doses are used for many days postpartum, which would be quite unusual nowadays, ergometrine can actually decrease milk
How's
secretion.
that?
It's due to a separate action. It has a dopaminergic action. It stimulates dopamine receptors, and dopamine inhibits the release of prolactin from the pituitary gland. Prolactin is the main hormone responsible for milk production, so less prolactin, potentially less milk.
Fascinating overlap. Okay, switching gears slightly within the stimulus category, let's briefly cover prostaglandins, PGGs. We often hear about them being involved in natural labor, but how are they used pharmacologically as stimulants?
Right. Prostaglandins, specifically PGE2 and PGF2, along with a synthetic analog called 15-methyl PGF2, carboprost, are incredibly potent uterine stimulants, particularly in the later stages of pregnancy.
What do they do?
They serve a dual purpose, really. They directly stimulate myometrial contractions like oxytocin does, but crucially, they also play a major role in cervical ripening.
Ripening.
Yeah, that's the necessary softening, thinning, effacement, and slight opening dilation of the cervix that has to happen before labor can progress effectively. PGs are key to preparing the cervix.
Okay, so they help get things started and stimulate contractions. Are they used often?
Yes, particularly for inducing labor when the cervix isn't yet favorable, or for medical termination of pregnancy. The sources also indicate a rising use of another synthetic PG analog, misoprostol, which is actually a PGE1 analog.
Why misoprostol?
It's often preferred because it tends to have fewer systemic side effects, like nausea and diarrhea, compared to the naturally occurring PGs like PGE2 and PGF2. It's also stable, available as tablets, and relatively inexpensive, making it very useful in many settings. Can be given orally, vaginally, or rectally.
Okay. And finally, under stimulants, there was this unique mention of ethacridine for termination.
Yes, ethacridine lactate. It's mentioned as a specific non-prostaglandin chemical compound. It's sometimes used, though perhaps less commonly now, for medical termination of pregnancy, particularly in the second trimester.
How is it used?
It's typically administered as an extra-amniotic infusion, meaning a catheter is placed between the fetal membranes and the uterine wall, and the ethacridine solution is slowly infused there. It acts as a local irritant and stimulant to induce labor. It's just another example, really, of the diverse chemical classes that can be employed to stimulate the uterus depending on the specific clinical goal. ###3, uterine relaxants, tocolytics, halting premature labor.
All right, we've thoroughly covered the stimulants, the go signals. Now we transition to the opposite challenge, the tocolytics. These are the drugs designed to achieve the exact opposite goal to decrease uterine motility, essentially to delay or postpone preterm labor. The clinical reason seems obvious, but the whole strategy sounds fraught with complexity.
The clinical urgency is absolutely immense. Preterm birth is a major cause of neonatal mortality and morbidity worldwide. So the primary goal of tocolysis is usually to suppress premature labor contractions to buy time.
Time for what, specifically?
Two main things, usually. First, precious time to transfer the mother, if necessary, to a hospital with a higher-level neonatal intensive care unit, NICU, a tertiary center better equipped to handle a premature baby.
Okay, transfer time.
And second, and perhaps most critically, time to administer a course of glucocorticoids steroids like betamethasone or dexamethasone to the mother. These steroids cross the placenta and accelerate the maturation of the fetal lungs.
Ah, the lung maturity aspect.
Yes, this significantly reduces the risk and severity of respiratory distress syndrome, RDS, a major killer of premature infants. Getting that steroid course on board often takes 24 to 48 hours, so stopping contractions for at least that long can make a huge difference to the baby's chances.
But, and this is a big but in the source material, it delivers a pretty significant reality check about how effective these drugs actually are in the long run. It states that no drug is clearly satisfactory. If the goal is so critical, why haven't we found a definitive solution?
It's a really tough problem because simply stopping the contractions for a while, say 48 hours, doesn't necessarily guarantee a better long-term outcome for the baby.
Why not?
Well, for one, the underlying issue that triggered the preterm labor in the first place, maybe an infection or placental problems, might still be present. So once the drug wears off, labor often just resumes. We might delay delivery, but not prevent prematurity altogether. And secondly, as we'll see, many of the tocolytic drugs available, especially the older ones, carry their own substantial risks and side effects for the mother. So the time gained for the fetus is often traded against potential maternal morbidity, sometimes quite serious morbidity.
So it's a trade-off.
It's always a risk-benefit calculation. And success is highly conditional. Tocolysis is generally only likely to succeed or even be attempted if the cervix hasn't already dilated too much. Typically, the cutoff is less than 4 centimeters dilated, and if the lower segment hasn't significantly thinned out and effaced, taking up is the term used. If labor is already too advanced, it's usually too late to stop it effectively.
So tocolysis is this high-stakes race against the clock, trying to buy time, but it comes with absolute stop signs too. When should a clinician absolutely not even attempt to stop the labor?
Right, there are clear contraindications where trying to stop labor would be harmful or futile. The attempt should generally not be made if the patient presents with ruptured membranes, water broken, especially if there's evidence of infection, chorioamnionitis.
Okay, infection is a no-go.
Also, if there's significant antepartum hemorrhage, bleeding before delivery, severe toxemia of pregnancy, like severe preeclampsia or eclampsia, where delivery is indicated for the mother's health, known intrauterine infection, or sadly, if there's evidence of fetal death or a lethal fetal anomaly. In these critical situations, delaying delivery only increases the risk to the mother or prolongs a situation where the outcome for the baby is already determined or where delivery is the safer option.
Okay, let's look at the major drug classes used for tocolysis, starting with the one that used to be the standard bearer, the adrenergic agonists, like ritodrine. So what does this aggressive attempt to halt labor using a beta-agonist actually mean for the mother's system? It sounds like it could have widespread effects.
It absolutely does, and that's the core problem with this class. It means accepting a very high frequency of systemic complications, side effects that significantly increase maternal morbidity.
Why so many side effects?
Because ritodrine works by stimulating based adrenergic receptors. While there are Baser's receptors on the uterus that cause relaxation, which is what we want, there are also Beast receptors everywhere else in the body and the heart. Blood vessels, lungs, liver, pancreas.
So you're stimulating all of them.
You're hitting all of them, and the protocol itself is intense. It typically involves a slow intravenous infusion, starting low, but then the rate is aggressively increased every 10 or 20 minutes until either the contractions stop or, crucially, until the mother's heart rate hits a ceiling, usually around 120 or 130 beats per minute.
Wow, pushing the heart rate that high is a sign of major systemic stress.
It is. It tells you the drug is having significant cardiovascular effects.
And what are the specific, distinct categories of complications that arise from this systemic stimulation?
They generally fall into two major baskets: cardiovascular and metabolic.
Okay, cardiovascular first.
Severe cardiovascular issues are common. You get significant hypotension, low blood pressure due to vasodilation in some beds, but also marked tachycardia, rapid heart rate, sometimes palpitations and arrhythmias. Chest pain can occur. And most dangerously, there's a significant risk of pulmonary edema fluid building up in the lungs.
Why pulmonary edema?
It seems to be a combination of factors. The fluid overload from the necessary 5e infusion itself, combined with the cardiovascular strain, increased heart rate, changes in vascular permeability caused by the drug. It can be life-threatening for the mother.
That sounds awful. What about the metabolic issues?
Also significant. VASE stimulation causes increased glycogenolysis, breakdown of stored glucose, in the liver and muscle, leading to hyperglycemia, high blood sugar. The body responds by pumping out more insulin, so you get hyperinsulinemia. And it also drives potassium into cells, leading to potentially dangerous hypokalemia, low potassium levels in the blood.
Wow. So blood sugar and potassium are way off.
Yes. Plus, the mother often experiences subjective side effects like anxiety, tremors, restlessness, nausea, vomiting, and severe headaches. It's generally a very unpleasant drug to receive.
Yeah, that really explains why ritodrine has been discontinued in the USA and some other places. The high cost in terms of maternal side effects seems to outweigh the conditional benefit of maybe delaying labor for a bit. What about risks to the baby, the neonate, after birth?
The risks can persist even after the baby is born. Primarily, there's a risk of neonatal hypoglycemia, low blood sugar because the baby was exposed to high maternal glucose and insulin levels in utero, and potentially neonatal ileus, sluggish gut function.
And who absolutely shouldn't get these drugs.
They're strictly contraindicated if the mother has pre-existing conditions like significant heart disease, uncontrolled diabetes because of the hyperglycemia, hyperthyroidism, or if she's concurrently receiving other drugs that could impact badly, like certain vol blockers or sometimes even steroids themselves due to the pulmonary edema risk.
Okay. Are there alternatives in this class?
Yes, other somatoagonists like salbutamol, albuterol, and terbutaline are sometimes used off-label for tocolysis, often given subcutaneously or orally. However, they carry a very similar high side effect profile because they are also non-selective uteroagonists. The fundamental problem remains the lack of uterine specificity.
Right. Okay. Moving to a mechanism that at least sounds more targeted. Calcium channel blockers, CCBs, with nifedipine being the main example used. Now, since we know calcium influx is absolutely central to that myometrial contraction cycle, blocking it seems like a potentially cleaner way to reduce uterine tone. Is it?
In many ways, yes, it represents a more favorable approach compared to the beta-rose agonists. Nifedipine is well known for its smooth muscle relaxant effect. That's why it's used for hypertension and angina. And clinical experience, including several trials, shows it can postpone premature labor with efficacy that's generally comparable to the beta-rose agonists.
But the key advantage is
The key advantage is significantly fewer maternal side effects, particularly the metabolic ones. You don't get the hyperglycemia or hypokalemia issues. And while there are cardiovascular effects, they tend to be less severe or anxiety-provoking than the intense tachycardia caused by ritodrine.
how is nifedipine usually given for tocolysis?
The standard protocol usually involves giving it orally. Typically, an initial loading dose, maybe 10 or 20 milligrams, sometimes repeated shortly after, followed by a regular maintenance dose, perhaps 10-20 milligrams every 4 to 6 hours.
But wait, nifedipine is a drug used to lower high blood pressure. If you're using it at a dose strong enough to relax the powerful uterine muscle, how do you manage the risk of causing severe hypotension, low blood pressure in the mother? Especially if she might already be stressed, maybe borderline preeclamptic.
That is the perpetual concern and the main side effect profile you watch for with nifedipine. Tachycardia, as a reflex to vasodilation, and hypotension are prominent potential side effects at these therapeutic doses. Flushing and headache are also common.
And the worry about the baby.
There's always the theoretical apprehension that if the mother's blood pressure drops too much, it might reduce blood flow through the placenta, potentially causing fetal hypoxia. That's the main safety concern.
But how does it pan out in practice?
In practice, while hypotension needs monitoring, severe complications seem less frequent than with the beta agonists. And interestingly, the sources note that some studies found that fewer babies delivered after maternal nifedipine use required admission to the NICU compared to those delivered after other tocolytic methods like ritodrine. So overall, the side effect profile seems better managed, and the risk-benefit ratio is often considered more favorable.
Okay. That brings us to the third major class, which seems to target the problem right at its source. Oxytocin antagonists like atosiban.
This represents arguably the most logical pharmacological attack, doesn't it? If oxytocin drives contractions at term, let's block its receptor.
Makes sense. How does atosiban work?
Atosiban is a synthetic peptide analog. It's designed structurally to fit perfectly into the oxytocin receptors on the myometrium, but instead of activating them like oxytocin does, it just sits there and blocks them. It acts as a competitive antagonist.
So it stops the oxytocin signal from getting through.
Exactly. It effectively intercepts and blocks the primary signal that drives uterine contractions, particularly those associated with established labor.
And the advantage?
Its major clinical advantage, shown consistently in trials, is that it effectively suppresses premature contractions and postpones delivery for that crucial 48-hour window, but with significantly fewer cardiovascular and metabolic side effects for the mother compared to the baroagonists like ritodrine. It's much better tolerated.
That sounds like a clear win. Why isn't it used everywhere? Our sources note an interesting geographical difference in its approval status, which suggests maybe there's still some ongoing debate over its overall benefit versus risk or cost.
Indeed, that's a key point. Atosiban is currently approved and widely used for inhibiting preterm labor, typically between 24 and 33 weeks of gestation in Europe and the UK. This suggests a generally favorable risk-benefit assessment in those regions.
But not everywhere.
Yet it remains unapproved for this indication by the FDA in the USA, and it's also noted as not approved in India in our source. This discrepancy highlights that consensus on the overall value, perhaps considering efficacy, cost, administration route — it requires FUVI infusion as it's a peptide — is not yet universal across different global regulatory bodies and healthcare systems. Regional differences in practice and assessment persist.
Interesting. Okay, finally under tocolytics, let's quickly cover the miscellaneous agents, starting with magnesium sulfate. It's almost legendary in obstetrics, but mostly for preventing seizures and severe preeclampsia or eclampsia. Why is its use specifically as a tocolytic now discouraged?
Right. Magnesium sulfate absolutely does have a tocolytic effect. Its mechanism is thought to involve competing with calcium ions at the cell membrane and potentially intracellularly, essentially interfering with the calcium signaling needed for muscle contraction. So it can reduce myometrial tone.
So why not use it for preterm labor?
Because over the years, data accumulated from studies specifically looking at its use to delay premature labor raised concerns. Some meta-analyses suggested it wasn't very effective at actually prolonging pregnancy significantly, and more worryingly, it was associated with an increased risk of perinatal mortality and potentially adverse neurological outcomes in the infant, although that remains debated.
So the risks seem to outweigh the benefits for that specific indication.
Exactly. Therefore, the current consensus, reflected in the source material, is that its routine use solely for the purpose of delaying labor is not recommended now. Its primary undisputed role remains the prevention and treatment of seizures in preeclampsia and eclampsia, where its benefits are clear.
Okay. What about prostaglandin inhibitors, like indomethacin? If PGs stimulate contractions, blocking them should relax the uterus.
Logically, yes. Indomethacin is a potent inhibitor of prostaglandin synthesis. It's an NSAID, like ibuprofen. And since PGs are important stimulants, especially in preterm labor, blocking their production can effectively suppress contractions.
But there's always a but.
The big but with indomethacin is the potential for significant fetal side effects, especially if used later in gestation, typically after 32 weeks, or for prolonged periods.
What kind of side effects?
The main concern is premature closure of the fetal ductus arteriosus, a blood vessel essential in fetal circulation that normally closes after birth. Closing it too early can cause severe pulmonary hypertension in the newborn. There are also concerns about effects on fetal kidney function and potential necrotizing enterocolitis.
So its use is very limited.
Very limited. It's usually reserved for very specific situations, often for short-term use, like less than 48, 72 hours, and generally avoided late in gestation due to those fetal risks.
Okay. And finally, the specialized role mentioned for halothane.
Halothane. This is a volatile general anesthetic agent. It's noteworthy here, not because it's used for routine tocolysis to stop preterm labor. It's not.
Then why mention it?
Because it happens to be an exceptionally potent and efficacious uterine relaxant. It causes profound relaxation of the myometrium as part of its anesthetic effect.
So when would that be useful?
It's used primarily in specific obstetric emergencies during delivery, often under general anesthesia, when the obstetrician needs the uterus to be completely relaxed to perform a maneuver. The main example is version either external cephalic version, trying to turn a breech baby before labor, or, more dramatically, internal pedalic version, reaching in to turn a second twin, for example. You need the uterus absolutely relaxed to do that safely and avoid rupture. Halothane provides that profound relaxation.
Got it. A tool for specific intrapartum emergencies. Any others mentioned briefly?
The source just lists a few others that have been tried or used with less efficacy or more concerns. High-dose progesterone, sometimes used prophylactically in high-risk women, mechanism unclear. Nitrates, like nitroglycerin, vasodilators would have some relaxant effect. And historically, even ethyl alcohol infusion, which is definitely not used anymore due to fetal risks. Hashtag VV. Synthesis and clinical challenge case application. Okay. We have meticulously dissected the pharmacology. We've looked at the drugs that start contractions, the oxytocics like oxytocin and ergometrine, and we've looked at the drugs that try to stop them, the tocolytics like ritodrine, nifedipine, atosiban. Now we face the ultimate test of professional mastery, applying this detailed knowledge to a complex real-world clinical scenario. This is why the decision-making really matters, potentially dictating the survival and well-being of both mother and baby.
Let's set the scene then. We have a full-term prima gravida first baby. She's 26 years old. She's admitted to labor and delivery. Here's the story. She's been in labor for a grueling 24 hours, but her contractions are weak and infrequent. A classic picture of uterine inertia, basically failure to progress.
Okay. Long labor, weak contractions.
Exactly. The cervix is incompletely dilated. She's clearly exhausted. Now, here are the critical pieces of information. 2 hours ago, she passed meconium-stained liquor. The amniotic fluid is stained with the baby's first stool.
Alarm bell number 1. Meconium staining often indicates fetal stress.
Right. And alarm bell number 2. The continuous fetal heart rate monitoring shows fetal tachycardia. The baby's heart rate is too fast, and there's noticeable irregularity in the heart rate pattern, especially during the contractions she is having.
Okay, so tachycardia and irregularity linked to contractions. That's alarm bell number 2, and it's blaring loudly. Clear signs of fetal distress.
Absolutely.
Yeah.
So here's the central question, the one facing the tired clinician in the middle of the night. Given the obvious uterine inertia, the weak contractions, can a uterine stimulant, specifically oxytocin, be administered to strengthen those contractions and hopefully expedite the delivery?
The temptation must be immense in that situation. You have a clear primary indication for oxytocin staring you in the face. Uterine inertia, failure to progress. The mother is exhausted, the labor has stalled. You desperately want to augment those contractions, make them effective, and get this baby delivered vaginally. It seems like the logical next step.
It really does. Just turn up the power, right?
Yeah. This is where mastery of the field, that deep understanding we've been building, separates safe practice from potential disaster. The clinician absolutely cannot give in to that temptation based solely on the weak contractions. Because mastery requires strict, unwavering adherence to that safety protocol, that pre-infusion checklist we hammered home earlier. Remember, the use of an oxytocic like oxytocin to strengthen contractions requires all 6 of those essential conditions for induction or augmentation to be met, without a single exception.
Okay, let's run the checklist mentally for this case.
Yeah.
Presentation we assume is okay, lungs mature, full term, probably no CPD, no placenta previa mentioned, no uterine scar, prima gravida.
Yeah.
But what about condition number 5?
Condition number 5 was no fetal distress. And in this exact scenario, we don't just have a hint of distress. We have not 1, but 2 glaring, unequivocal, universally accepted markers of acute fetal distress.
The meconium staining.
And even more acutely worrying, the ongoing fetal tachycardia and irregularity on the monitor, specifically worsening during contractions. This tells us the fetus is already struggling to cope with the physiological stress of even the existing weak contractions. Its reserves are low.
So the answer to the question, can we give oxytocin, has to be
An absolute, unequivocal, emphatic NO. Not just no, but hell no.
Why would it be so catastrophic?
Because administering a uterine stimulant, especially oxytocin, in this situation would rapidly increase the frequency, the duration, and the intensity of those uterine contractions. Each stronger contraction would further compress the placental blood vessels, drastically reducing blood flow and oxygen supply to a fetus that is already showing clear signs of oxygen deprivation and stress.
So you'd push it over the edge.
You would almost certainly precipitate acute, profound fetal asphyxia. You risk neurological damage to the baby, or worse. You also significantly increase the risk of uterine hypertonus or even rupture given the long labor. It would be pouring gasoline on a fire. The immediate clinical course must pivot entirely away from augmentation.
That really highlights that razor-thin margin we started with. Ruling out the stimulant here, based on fetal distress overriding the maternal indication of inertia, means the immediate plan has to shift completely, doesn't it?
Completely. The focus instantly shifts from trying to achieve vaginal delivery via augmentation to emergency intervention to rescue the distressed fetus. This almost certainly means immediate preparation for an emergency cesarean section. The priority becomes getting the baby out of that compromised uterine environment as quickly and safely as possible before irreversible harm occurs. It's a critical decision point where knowing the contraindications is more important than knowing the indications. #outro def.
So after that deep dive, what does this all mean for you as the learner, for someone who now possesses this really specialized knowledge about uterine pharmacology?
Well, I think it means understanding that this field is really defined by, let's say, 3 powerful chemical approaches, each with its own incredibly rigid protocols and distinct place. You've got oxytocin, we call it the peptide scalpel.
Right.
It offers precise, rapid control over contractions, but its safety absolutely hinges on confirming that every single one of those pre-use safety checks is clear. It's ideal for careful augmentation when conditions are perfect.
Then, in stark contrast, you have ergometrine, the powerful alkaloid sledgehammer.
Exactly. Its use is restricted almost exclusively to stopping that potentially catastrophic hemorrhage after delivery is complete because of its powerful, sustained tonic action on the whole uterus and its significant systemic vascular risks. You absolutely don't use it during labor.
And finally, you have that complex, often challenging landscape of the tocolytics, the drugs trying to stop premature labor.
Yeah, and here we understand the difficult trade-offs. We see the high price associated with the older Deriers agonists like ritodrine, where significant maternal systemic side effects were basically traded for that precious potential gain in fetal maturation time.
Hmm.
And we also see the promise and perhaps the limitations of more targeted mechanisms, the calcium channel blockers like nifedipine offering a better side effect profile, and the oxytocin antagonists like atosiban being perhaps the most logically targeted, though not universally adopted yet.
It really drives home that in this specific field, maybe more than any other, drug choice doesn't just hinge on pure efficacy. It's always about this severe, constant risk-benefit analysis, demanded by the unique situation of simultaneously treating two patients with potentially conflicting needs.
Precisely. The mother's safety versus the baby's needs. And the source material itself points towards newer agents like atosiban offering perhaps a superior risk-benefit profile for tocolysis compared to the older drugs. However, even atosiban, being a peptide, still requires 5-IV administration and isn't free from potential issues or cost considerations.
Right.
And given that enduring challenge, that reality check that no current tocolytic has definitively, reliably improved long-term fetal outcomes across the board, well, it raises a crucial and I think quite provocative thought for you, the learner, to perhaps explore further.
Okay, what's that?
How might the targeted development of highly selective, perhaps non-peptide oxytocin antagonists imagine drugs that could potentially be delivered orally, maybe with even fewer side effects, perhaps zero cardiovascular or metabolic risk to the mother? How might that kind of innovation truly revolutionize the management of preterm labor across the globe? Especially thinking about resource-limited settings that might currently rely on older, riskier, or simply less effective compounds. It's really the ongoing search for a drug that effectively buys that critical time for the fetus without demanding such a high physiological price from the mother. That would be a game changer.